Well, everyone, thank you very much for attending and listening in on this 11th annual Fellows Interventional Pain Management Fellowship course. I'm so happy to have such a great turnout in the audience here today, here at the Seattle Science Foundation. Myself, as well as Dr. Douglas Beal and Dr. Jennifer Lee as co-chairs. We are glad to have you. A lot of our faculty have come from across United States here, as well as Canada, to volunteer their time to help teach the next generation of fellows. And we have a fellow here. So, introduce yourself to us.
Yeah, sure. I'm Sajjan Shah. I'm currently a pain fellow at Stanford. Did my residency in anesthesia prior to this.
Excellent, excellent. Have you ever done a procedure like this before?
I've seen one. I haven't participated in one just yet.
Okay, excellent. Well, wonderful. So you met Dr. Peter Nora, and I have to say what a wonderful colleague he is and the surgical partner he is here at the Swedish Neuroscience Institute. It's so important to have surgical partners in our practice, and to run things by, collaborate on different cases, and the importance how we can take care of our spine patients in the utmost way. Today we'll be going over the Vertos mild procedure, minimally invasive lumbar decompression by Stryker. Here I also have Cindy. Cindy, saying hello, who is going to help us here, a representative from Vertos. We're going to be going over the mild procedure itself. We have, can you see the actual X-ray here? Excellent. As you can see, we kind of lined up the interlaminar space at the L4 or 5 level. So we're looking at how can we help our patients with, in a minimally invasive way for lumbar stenosis. Patients that have that, we'll go over that, a little overview of lumbar stenosis later on. But patients are having quite a bit of pain when standing and walking. You're looking on their MRI, and they're having quite a bit of stenosis occurring at the in the interlaminar space. There's a lot of hypertrophy of the ligament. There's also hypertrophy of the facet joints, the degenerative disc coming into the canal. But here we're trying to treat the hypertrophied ligament, and we're going to be going over this procedure to help to take some of that ligament out to help provide more space for the nerve roots to travel through the canal. Okay? So we kind of had a marked space here on our AP view of our cadaver here. Picture there. And picture here. We're starting anywhere from a vertebral body to a vertebral body space below our targeted L4-5 interlaminar space. We're making just a incision with the, sure. Thanks so much. The scalpel, just to give us room for our trocar cannula instrument, and I'll show you that in a second. So we can use our spinal needle to help kind of give us our proximal trajectory. We're going to give a midline approach at first, and then kind of shift over to the side. Picture. But land it, picture there. Picture there. Picture there. There. Picture there. Let's use mine. So the nice tools from the Vertos kit here. Picture there. To get a nice and land at the base of the interlaminar space there. Okay, a nice trajectory in that. A little bit of a acute angle, but should be get there quite nicely. And picture there. So if you want to look at the actual instrument, Close up of the instrument itself. Trocar and cannula instrument that we're using and placing it where we put our spinal needle. It's a midline approach, so we can go on either side. Picture there. Okay, picture. 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 And we are orienting that midline. Picture. Picture there. Picture there. Picture there. And hitting the lamina there. Picture. Picture. Picture there. Excellent. And we'll go to now a laminar view. And I think this laminar view is 50 degrees, approximately 45 to 50 degrees we're at. So this is an important view for getting an interlaminar epidural steroid injection. And this is a view I want our fellows to be very comfortable with seeing, okay? So we can see where we're at this point. We can see and we can look at the shelves of the interlaminar above and below at the interlaminar space at L4-5. I'm gonna point those out. Picture here. Here. So you can shelve at L4, the superior portion, picture here, a superior shelve there, picture here. Picture here, here. So we're looking at the underside, picture at L4, picture. That's what we're gonna be targeting there. Sorry, a little feedback there, picture there. And we're targeting the superior side, picture that, picture there. There of the inferior shelf there, picture. Okay, and we can be basically using that bone rongeur once we get in place. Picture there. Picture there. Picture there. Picture there. Picture there. And there. There we go, picture. And here, picture. There we go. And at this point, we're going to switch over to the bone rongeur and put our stabilizer here. The wings go towards the head. Yeah. The product body can seal that, though. But it has a little orientation guide to make sure facing the right way. Putting that stabilizer, clicking that into place. Picture there. And move a little bit, picture. Picture. Yeah. And then also the depth gauge. We're using the depth gauge mainly to help make sure we're not getting too far into the interlaminar space and passing that laminar line. Picture there. Neil, you want to show them, our audience and our fellows there, the laminar line? Neil, can you hear me?
Yeah, we're pointing it out with a pointer.
Thank you so much. I just can't hear you guys. Thank you. Also, if we look at the instrument here, the bone rongeur helps provide some cuts and pieces. So it helps to provide some cutting edge there to help cut into the bone there that it's attaching to the laminar surface, to the ligamentum flavum. And this fashion will be holding it in this fashion. To get at the inferior shelf there at the L4-5 interspace, picture there. And there. Picture there. And there. Picture there. And then kind of windshield wipering it, or kind of doorknobbing it in. Picture there. Picture there. And at the same time, I'm adjusting the depth gauge to get a little deeper. Picture. Picture there. And just continue to doorknob that in. And you can see in that fashion lightly. Picture there. And just be careful, you're not getting too close to that laminar line. Picture there. And a little bit more. Picture there. Picture there. And there. Picture. And there. I can take a bite here. Picture there. I'll be pushing this a little back a little bit further. Yeah. Picture there. Yeah. Nice. Picture there. Picture there. And take a nice bite here. Pulling out.
Nice.
Have a nice, you can look at more closely. You can see some of the ligamentum that you're seeing there. I can't see that very well, but if you want to look at the actual towels, you can see some pieces there. You're taking 2 to 3 passes in this fashion. Picture there. Looking at the x-ray. Picture there. Picture there. Picture there. And to gently kind of doorknobbing it in. Picture there. Picture there. And there. Yeah, picture there. Picture there. Picture there. Picture there. And there. Yeah, feeling the bone there. You get a bite there. Let's have a look. And cleaning it off. You take, anyway, I said, anyway, 2 to 4 passes there. And then I'll show you how we get after the superior surface there. Picture there. 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 And there. Picture. There. Picture there. Picture there. There. And just slowly windshield wipering it in. Picture there. So a lot of times you'll get an epidural injection for this patient, you know, a few weeks, a few months beforehand, making sure that, you know, seeing if the patient's responding to an epidural steroid injection, but also you can use that to help provide information for this procedure. Picture there. Because that epidurogram can help you roadmap where that laminar line actually is. Picture there. Picture there. And take a little bite here. There's definitely a lot of there, helping to clean that out.
So Glenn, your comment there is that,
Just more space, and then we'll switch over to the, eventually to the, picture there. Picture there. And there. And there. Picture that.
so Glenn, your comment there is that, can you hear me?
I can hear you, yeah, go ahead.
Okay, that when you're doing a ESI in preparation for doing this procedure, that you capture fluoroscopy views of the depth of your needle when going through the ligamentum flavum, because you're decompressing some of that ligamentum flavum with this step of the procedure. And if you already have a previous x-ray that shows you depth,
That's exactly it. Because actually, when you actually do an epiduragram, you can actually see that I'm well behind and actually posterior to the actual interlaminar line. So very safe procedure. This procedure has 2 level 1 trials, or RCT trials. So good evidence behind it, improving ODI and improving pain as well. So good evidence behind it. A lot of patients can do very well with this. Its safety profile is very similar to an epidural steroid injection. So now we're going to switch over to the tissue sculptor, picture. Can you see that there? Can we focus in on the tip of the tissue sculptor? Thank you. So as you can see, the top of it has a little bit of a cutting edge to it, but also it's used to kind of scoop the actual ligamentum flavum. And I'll show you how it's done under X-ray guidance in a second here, but it's in a scooping fashion to actually get some of the ligamentum flavum that you left from the actual bone rongeur. Picture there. Picture there. And picture there. Picture there. Picture there. Yeah. Okay. Picture there. Picture there. Picture there. And there. And there. You can get the 3 passes, but I have quite a bit of tissue already, as you can see here. Picture here. Picture there. Picture here. And picture here. Nice cut here. Quite a bit of tissue there. And use a plunger there to help kind of plunge out the tissue through the space of the instrument. And it helps collect up the 3 passes, what I just did. And then after that, you can then plunge it out, help open up that space. Picture there. Excellent. Okay. So you would finish up with that. You would then back up the instrument cannula and then proceed to get the space done on the opposite side. And then pull out the hardware. You can back it up, do another space above or below, but in this case, above, in this approach, and get the other space just above it done as well. But as you see, if you want to see the actual cadaver at the surface, picture there. So very little skin glue there. But yeah, very well tolerated procedure. Safety profile very similar to an epidural steroid injection. Questions?
Yeah, do you ever do any component of this under live fluoroscopy as you're scraping?
Yeah, you can do under live fluoroscopy. We're doing under live here, especially with a tissue sculptor as well as the bone rongeur. Keeping it, we also do under pulsed. You really want to reduce the amount of radiation you're getting and being aware where the radiation is coming from, opposite the eye. But good point, yeah.
So those are just, so you're like watching the spinal laminar line, making sure you're not passing
You're
that
not
safely.
passing it, exactly. Yeah. You're going to be very careful. Again, another reason why getting an epidural injection and using that epiduragram that you created with the epidural injection helps improve that safety profile for this as well.
Glen, can you go back to the oblique? Because I want to point out to the audience that this is a classic case
I can barely hear you. Sorry, Neil.
Can you hear me better?
Yes, yes.
Okay, so I was going to point out to the audience, this is a classic case of what you'll see come into the office. This patient has an occult spondylolisthesis at L4-5, has a preserved disc space. So the majority of the MRI findings on this are going to be hypertrophy of the ligamentum flavum. So the sculpting technique and the rongeur technique, Kerrison technique, are addressing the fundamental pathology. If you could go to the AP for just a second,
Sure.
Is that still saved? And what a surgeon would do in a open setting, in this setting you're coming in on the left and you're going to come in on the right. What a surgeon would do in an open setting is create a rectangular decompression of this zone where the majority of it is soft tissue. And that's done through an open incision. And if you can accomplish successful decompression with what essentially is an incision the size of a paper cut, that really is, you're going to put this incision back together again with one stitch maybe, or with a butterfly tape. Yeah. You're accomplishing the same goal. And in patients who are at risk for surgery, this is an excellent option for achieving the same benefit. Thanks, Glenn. Any other questions from the audience, please?
I just have a comment. There's a question about live fluoro. Don't do a lot of live, just pictures. It's too much radiation. But if you want to get an idea with your depth stop to make sure your depth stop is in the right location, you can do live, especially with the Kerrison punch. You just get in there and do live and make sure you're not going too far past the spinal laminal line, the posterior pedicle line that demarcates the dura. So if you want to do that, get your depth stop, and then put the reason why there's a depth stop on that cannula is so you don't go too far, and so you have a marker about your depth. But mind the radiation.
No, that's a good point, Doug. We all anticipate very long careers. It's a scenario where we're. Oh, can you hear me? Can you hear me now? Or reduce the amount of radiation as possible. So, yeah, I tried to use pulse if I want a little bit of a more live view, but intermittent pictures, there's a little delay in our C-arm, so it actually seems like there's a little bit of live pictures here while I'm actually doing the scoop. So I was like, oh, yeah, it looked like a little live scenario here. But
Glenn, I'm going to take a question from the audience.
please.
So neurosurgeons are usually concerned about this procedure because they lose the safety zone. Like, I mean, for
Can you
future
hear that,
surgeries.
Glenn?
What's your comment on that?
I can barely hear him.
Speak right into it.
So neurosurgeons are usually concerned about this technique because they lose the safety zone, like in the future, like for future surgeries. What's your comment on that?
So they're concerned about the safety zone. Is that your question was?
Yeah, exactly. For future surgeries, like, I mean, just like it eliminate the zone, like the safety zone for them for like to approach the dura. So,
Glenn, let me take that because I do open
I'll give my
surgery.
opinion as well, but go ahead, please, Neil.
Yeah, I do open surgery all the time, and 1 out of 7 of my laminectomy patients, open laminectomy or MIS laminectomy, unilateral, bilateral, have recurrent disease over a 7 to 12-year period of time. So I'm going back through the quote-unquote safety zone all the time. So revision surgery is really, once you get to be an older surgeon, that's mostly what you do, is revision surgery on patients who were successful in your practice earlier. So you don't lose the capacity to follow up with a decompressive procedure. It may be easier to do a minimally invasive open procedure, but with skill set, you can proceed with minimally invasive technique like this. And Doug, your comments?
Yeah, sure. They're concerned
then Glenn
about
will
the
get to you.
increased propensity for dural tear. Dural tear is in the low single digits in terms of what Neil just said. MIS decompression, a hemilaminectomy, laminectomy. If you go back, the rate of dural tear goes all the way up to about 25 to 27%. And so it just increases the risk of dural tear. But as Neil said, that's just part and parcel with spinal stenosis decompression, and we'll have to go back and do it again. So there's no sense that doesn't eliminate the need and the essence of having something that's really minimally invasive. And the last trial that just came out that Veritas put out is it decreases the rate of surgery dramatically, additional surgery. So this can be thought of as an entry-level decompression. And I think it should be thought about that. And if the surgeon is worried about going back and doing another hemilaminectomy or MIS or open decompression, then, find another surgeon.
Glenn, you were going to comment. Glenn? Well, then I'll carry a conversation a little bit further until Glenn gets back on. The comments that Peter Nora made earlier on around Glenn, you were going to make comments.
Yeah. No, as you were saying earlier, no, you can still do a decompression here. It doesn't keep you from having our spine surgeons getting a laminectomy or laminotomy done. I think Neil definitely agrees here in this situation. So I think that it's a little bit of a scenario where, yeah, they're worried that we're getting into an area where we're getting too close to basically the lamina and the interlaminar line. And but it's a scenario where, as we all saw, that you can do this in a very safe fashion. The safety profile is very similar to an epidural steroid injection, which we do quite often in our practice. So.
And let me circle back to Peter Nora's comment of collaboration, especially when you come out of your fellowship and you're just getting connected in your community. One of the very first people you should introduce yourself to are your surgeon colleagues whom you can call on to share patients and to give you a helping hand. And so if complications were to arise and they need an open resolution to the complication. So in this scenario, you might be doing the first 10 or 15 of these as virgin cases. And if something comes about that didn't get complete decompression, the patient is still symptomatic, then you'll be seeing your surgeon colleague and say, hey, this one didn't work as well. Could you go in and take a look, or can I go in with you and look over your shoulder? And you see the effectiveness of what you did, and you see the residual compression that remained and why the case didn't go as well as, and it goes in your head, and you develop a relationship with someone in the community. Because you are eventually going to go away, and either your partner is going to take your call or something's going to happen. And if you have backup at all times, your community is safer. And yes, please, Jennifer.
I'm curious about other faculty's opinion about the use of an epidurogram in a case where there is moderate to severe stenosis or a history of previous surgery at that level. Does any of the other faculty use this?
I think it's optional. I use it sometimes. So in more complicated cases, just as you said, Dr. Lee. So if you want to do an epidurogram, do it. And we use it more for adequacy of decompression more than anything else. If it's a complicated case prior surgery, we do an epidurogram on everybody. And why would you not want to see it? I think if you're just starting out and you don't do an epidurogram, I don't know if we can be friends anymore. Look, this is something that if you're really expert and you've done hundreds of these, you may get away from not doing it. But until you reach that level, how do you know you're done? How do you know you're finished? Can you see it? No. So it's not like doing it through MIS or under a scope or with loops. You can't see it. So you're going to have to do the surrogate of visualization is the epidurogram.
We also know there's I'm interested in the faculty's opinion also of any thresholds for the severity of stenosis beyond which you would not consider this procedure.
No, I mean, it's a yes and no. So yes, it works best for moderate severe stenosis. Would you do it on severe stenosis? Well, it depends, right? I mean, if the person's 88 years old and they don't have any ability to do general anesthesia or deep sedation at all, then sure. I mean, doing this under MAC, and we get really good results for patients like this. So I think it's, technically it's for the moderate to severe stenotic patients, but there are exceptions clinically.
Thanks, Doug.
So Dr. Dan Nelson is an interventional pain colleague that I have shared patients with for decades. He's been practicing in the Pacific Northwest for decades, and he brings a skill set in intervention that many of us, at least in my practice in the surgical field, we do not have familiarity. So much of what Dan is going to talk with you about are things that are going to be arrows in your quiver, because it really expands your ability to benefit patients. Dan?